Welcome, everybody. This is Dr. Joseph Shams. I'm the medical director of Manhattan Division of American Endovascular Care, and we have a nice case for you today to discuss chronic limb ischemia. This is an 83-year-old female who presents with gangrenous ulcerations of her right big toe, the right plantar forefoot, and the right heel. The patient had previously undergone revascularization at an outside institution about 2 months ago with some improvement initially, but then progression of the ulcerations to gangrene. She also complains of severe rest pain of the toes bilaterally. Past medical history is significant for hypertension and stage renal disease. She's been on hemodialysis for approximately 3 years, hypothyroidism, and she is on clopidogrel, but that's it for her antiplatelet regimen. On physical examination, the right foot is cold to touch. Skin is dry and scaly in appearance with ruberous toes. Dry gangrene is noted at the tip of the big toe, the plantar forefoot between the third and fourth toes, and the heel. Late capillary reflow of the toes greater than 1 second is noted, and absent hair distribution. No edema is identified, and the left toes are also ruberous. On pulse examination, the right femoral pulse is 1+ palpable. The left femoral pulse is 1 to 2+ palpable. The right dorsalis pedis artery pulse is non-palpable with a non-Dopplerable signal. The posterior tibial artery pulse is non-palpable with a weakly Dopplerable monophasic signal. The left dorsalis pedis and posterior tibial are also non-palpable with weak Dopplerable monophasic signals. Treatment plan was for lateral evaluation. Routine lab work was drawn at our office, and for arterial imaging with Doppler. The arterial ultrasound exam demonstrated multiphasic signals within both common femoral arteries. On the left side, there was a decreased velocity on the left common femoral as compared to the right. And there was increased velocities in the proximal superficial femoral artery on the right, and the distal superficial femoral and popliteal arteries, and occlusion of the tibial vessels. Treatment was an angiogram and planned revascularization of the right lower extremity vessels by a left femoral approach. These are pre-treatment pictures. We can see there's a spotty gangrene at the tip of the right big toe, spotted gangrene in the right heel region, and also, you can see it well, between the third and the fourth toes along the plantar aspect of the forefoot. This is an aortogram, was performed via a retrograde left common femoral artery approach, demonstrating patency of the common iliac and external iliac on the right side, but close-up view, we can see there's a very tight lesion, greater than 95%, within the mid portion of the external iliac artery. Scout images of the right leg demonstrate metallic stents extending from the mid portion of the superficial femoral artery through the mid portion of the popliteal artery. And also we see what was presumed to be a drug-eluting stent within the tibioperoneal trunk. Here we see angiography views. There's significant stenosis within the proximal portion of the superficial femoral artery, extending for several centimeters in length. The stents within the distal SFA are patent. There's some irregularity within the stents in the popliteal artery, and also stenosis within the mid-popliteal artery behind the knee joint, stenosis within the distal popliteal artery. There is some contrast flow within the tibioperoneal trunk stent with slow contrast flow, and then occlusion of the posterior tibial and peroneal arteries beyond the stent. Here we see a collateral flow. This is a view of the proximal to mid calf. We see there's basically collaterals that are draining down the leg, and we're reconstituting the posterior tibial artery several centimeters above the ankle. Posterior tibial artery reconstitutes here and does extend into the foot where it supplies the lateral plantar artery. Here's again, showing how calcified the vessels are from this level. So first, the external iliac artery stenosis was treated. A 7 by 4 millimeter smart stent, non-covered stent, was deployed across the stenosis and was dilated with a 6 millimeter by 4 centimeter gladiator angioplastic wound with an excellent cosmetic result. I should note that IVUS exam was also performed for vessel sizing of the iliacs and the SFA at the top and the tibio-peroneal trunk. The posterior tibial artery occlusion was crossed with a 0.014 inch command guide wire, and the guide wire was advanced into the lateral plantar artery. IVUS exam performed with a 0.014 inch volcano IVUS, demonstrated no thrombus within the stents or the runoff vessels. Laser atherectomy of the superficial femoral artery, popliteal artery, and posterior tibial artery lesions was performed using a 1.4 millimeter Spectranetics laser fiber. Supplemental percutaneous angioplasty of the superficial femoral and popliteal artery stenoses was performed using a 5 millimeter diameter Sabre balloon. And supplemental angioplasty of the tibio-peroneal trunk and posterior tibial artery stenosis was performed using 2.5 and 3 millimeter diameter Sabre angioplastic balloons. Here's the post-intervention images. Again, here's the superficial femoral artery. Remember, we had pretty severe stenosis within the proximal portion of the superficial femoral artery. Here we have a nice, clean appearing superficial femoral arteries, mild recoiling within the mid portion of the SFA, but otherwise widely patent. Stents are now widely patent throughout. Here we see the distal popliteal arteries now widely patent. There's a tibio-peroneal trunk extending into the posterior tibial artery, which is now widely patent throughout. And we have straight line flow down the posterior tibial artery into the lateral plantar artery. This is some pre and post images. This is pre-intervention. This is 8 weeks following intervention. Patient experienced immediate increased sensation and warmth in the foot. She was kept on aspirin 81 milligrams and Xarelto 2.5 milligrams twice a day for 3 months. The gangrenous ulcerations completely healed over a 2-month period. Left lower extremity intervention was performed at a later date. Some discussion. Always check femoral pulses prior to intervention. If asymmetry is identified, suspect iliac artery lesion, even if ultrasound exam is equivocal. And in this case, there was no indication from the ultrasound report, except for a change in velocities, that there was going to be such a significant external iliac artery lesion. To attempt to reestablish straight line flow to the area of the wound to optimize healing potential. IVUS exam is very helpful in characterizing lesions, determining if thrombus is present, and sizing the vessels for treatment. I use IVUS routinely in almost all my CLI cases. Aggressive intervention can result in complete healing in some advanced cases, such as this one. Thank you very much.